Welcome to today's webinar. My name is Berit Müller-Peabody. I am the chair of today's meeting. So we would like to introduce today the international point prevalence of healthcare-associated infections and antimicrobial usage in England, planned for later this year, 2023. Many thanks to everyone who is joining us today. We have colleagues from England, Wales, and Northern Ireland online, which is fantastic. And of course, a big thank you to our presenters. But now I would like to hand over to Professor Susan Hopkins, UKHSA's Chief Medical Officer, who will give the welcome address. Susan, over to you.
Good evening, everyone, and welcome to well over 130 people. Sorry if there's going to be pinging noise in the background. I can't seem to stop the pinging on my computer anyway from those waiting in the lobby. It's a great pleasure to see many recognised names, if not faces, coming into the call. And it's a really great opportunity to get together as an infection community to think through the components of the National Point Prevalence Survey. The important thing to say today is that I have had a long life looking at national prevalence surveys, both as a hospital doctor, participating in prevalence studies in the 90s and noughties, both in Ireland and the UK. And then from 2010, developing and leading the national prevalence study in England, and then working across the UK collaboratively to deliver the national prevalence studies across the UK for the European point prevalence surveys. These surveys have been really important, and actually what we could see, and when we look back over all of the prevalence surveys that have been conducted, is the rise and fall of various different pathogens, particularly the rise of MRSA and C. diff. And these surveys have allowed us to understand in more detail, before we had national surveillance systems, what the organisms and infections were happening in our patients. It's also really important because it goes beyond bloodstream infections, and it is the only snapshot we have of other types of infections that take place holistically in a healthcare setting. So we can see what happens on different types of wards. We can see what happens on different types of patients, the age groups of patients, and we also can see the different aspects of urinary tract infections, pneumonias, respiratory tract infections, and the variety of surgical site infections that we see as well. For those that are not as long in the tooth as me, it may be interesting for you to know that in 2011 was the first prevalence survey that incorporated antimicrobial use as well as healthcare associated infections. And actually, that survey allowed us to incorporate antimicrobial use surveillance into the national surveillance that we do across the UK. And that was really important because prior to that, we had no national monitoring system for antimicrobial use in hospitals, something that I think we now will take for granted. We would be shocked, I think, to go back to a situation where we didn't know how much antibiotics were being used in each of our hospitals, and also what types of antibiotics were being used and for what types of condition. So I think that's a really important impact. It's also been really important in understanding the burden of infections in ICUs, where we have the most highest burden of healthcare associated infection and the commonest use of broad spectrum antibiotics, and therefore allowing us to focus on the actions that can reduce the burden of healthcare associated infection in this cohort. For example, in 2016, just under 1 in 5 ICU patients had an infection, and about half of ICU patients were on antimicrobials. We also found that about 1 in 12 patients were on prophylactic antibiotics, and almost half of those that were on prophylactic antibiotics were on antibiotics for longer than the recommended doses. And these findings led to incentives to improve antimicrobial stewardship and prescribing, and this will ultimately save lives. It was really good to see at the Antibiotic Guardian Awards that many individuals and many hospitals do local prevalence surveys and do ongoing sharing of their learning across the human and animal health sector. And really important, as we're here at the Point Prevalence Surveys, to highlight that you can, of course, continue to take Antibiotic Guardian pledges. And of course, this data that hopefully you will collect this year can be very useful for focusing people's minds on antimicrobial use and healthcare associated infection in your hospitals. And I would urge you that if you are participating, to ensure that you engage widely across the hospital before you start, with surgeons, physicians, nurses, pharmacists, and with your executive teams in hospital, so that they want to hear the outcomes and that they can work with you to improve the care of our patients, the use of antibiotics, and reduce healthcare associated infections. So this is going to be the 6th National Survey of Healthcare Association Infections and the 3rd National Survey of Antimicrobial Use. It will be an absolutely crucial year for us to understand what has changed in healthcare associated infections and antimicrobial use for community onset and hospital onset infections since this SARS-CoV-2 pandemic, and to understand what the new baseline should be for this country. I really hope that many of you will participate. I hope that you'll hear the tangible benefits over the course of this call today on the benefits of participation for your trust, for the country, and also vitally for what we will do over the next 5 years, nationally, regionally and locally, to improve healthcare associated infection surveillance and action from that surveillance, to improve antimicrobial use, and to therefore preserve antibiotics for the next generation of patients coming through our hospitals. I wish you a very successful meeting. I'll be listening in the background as I travel from Chiltern back to London for the next hour or so, and look forward to hearing the outcomes of your discussions.
I mean, your support. Thank you very much. Your support, Susan, of course, is crucial to this. So many, many thanks. Now to our next speaker. So the next sort of session is about the value of national point prevalence surveys. And we are being joined by 3 colleagues, Dr. Russell Hope, the Deputy Director, HCAI Fungal AMR AMU Sepsis Division here at UKHSA, Dr. Kieran Hand, the AMR National Pharmacy and Prescribing Clinical Lead at NHS England, and Dr. Diane Ashira-Oridopi, Lead Pharmacist, HCAI Fungal AMR AMU and Sepsis Division, again here at UKHSA. Russell, can I hand over to you?
Certainly, thank you, Britt. So, just going to go over some of the points that Susan made, really, but with some pictures. Why another PPS? Well, one of the key reasons is because things change, and this is very true of HCI prevalence. So some of our more infamous healthcare-associated infections, Clostridium difficile infection, and MRSA, bloodstream infections. Here you can see them on the screen in front of you, the trends over time, and we saw fantastic reductions in these 2 infections. But you can see that depending on where you placed your PPS surveillance, you'd get a very different impression of the prevalence level at that particular time. Next slide, please. So why now? So one of the key reasons in my mind is that the COVID-19 pandemic disrupted a lot of the trends that we see in our infections, and as we came out of that pandemic, the changes are not uniform. So depending on the particular infection you're looking at, or even the species of bacteria, then you could see very different trends emerging. And you can see some of those here on the slide. So if you look at E. coli, for instance, the blue line with the red trend tracing through it, giving you the average of the actuals. The green line is the the sort of like projected trend had COVID not occurred, so just continuing on that previous trend. And for E. coli, you can see the numbers dropped considerably. Whereas if you look at C. difficile infection on the bottom right, you can see that actually C. difficile continued to increase through the pandemic and has far exceeded what we were seeing just pre-pandemic. And that's why it's important for us to establish that sort of prevalence level now as we come out of COVID. And it's also a critical time for our AMR National Action Plan, because we're coming to the end of one and we're going to be starting another. So having a sort of like snapshot at the end of that 5-year National Action Plan is fantastic timing for us. So next slide, please. So I've shown you some data from some of our sort of like routine surveillance, some of our mandatory surveillance for some of our sort of like recognised key healthcare associated infections. But the PPS does much more than that. It doesn't just focus on those usual suspects. It gives you a broader view. For UTIs, in fact, it will even capture infections where we don't have microbiologically confirmed cases. It captures additional epi data, so it'll tell you the source of the infection in relation to bacteremias, for example. It'll tell you whether certain devices were used, which is very difficult to get with routine data. Not only does it inform us on the infection data, but it also gives us detailed data on the patients that don't have an infection, and that is something that we don't normally collect. Normally our surveillance is focused very much on the infected individuals. We get the granulation down to ward level. Normally this is down to trust or trust site. We can't normally go below that. And this enhanced data lets us deliver better models of infection, both in terms of determining where we may have where we may bring interventions in, but also the impact both in terms of patient outcomes, but also economic issues as well. And yes, we can do a lot more now than we could before with routinely collected data and data linkage, but you always have an issue of knowing whether it's telling you the right thing. So being able to sense check what we can do with data linkage and the infection data, and sense checking that with the PPS result is going to be very important to us as well. And of course, it's not just I've been talking about infections, but it's not just infection data that's captured by the PPS. It also captures antimicrobial usage. And for this, I will pass you over to Kieran Hand to talk to you a bit more about stewardship and AMU.
Thanks, Russell. And as Berit mentioned earlier, I'm the AMR prescribing and pharmacy lead at NHS England within the AMR programme. I'm going to focus on antimicrobial stewardship, but I know my colleague Sam Matthews will be talking about healthcare associated infections later on in the session. Next slide, please. And again, thank you. We don't need to persuade this audience, but new data from the Graham study, specific for the United Kingdom, demonstrate the burden of deaths from sepsis. This is the consequence of sepsis, over 110,000 deaths a year, and this is for 2019. Most of those bacterial infections, but really significantly, 35,000 deaths associated with resistance and 7,500 attributable to resistance, mostly from respiratory tract infections, bloodstream infections, intestinal and UTI. Next slide, please. So where does NHS England come into the picture? The priorities for NHS England were set out by our Chief Executive, Amanda Pritchard, and on the left, to set strategic direction for the NHS, to allocate resources, to provide supportive oversight, and to drive transformation. And there are lots of ways that the National Point Prevalence Survey enables us to fulfil some of those priorities. So continuing to raise awareness of the threat of AMR and keeping it on the radar of hospital leadership teams. So we would like to encourage everyone on the call to, if they can at all possible, to participate in the National Point Prevalence Survey. We hope to collaborate with UKHSA colleagues on the analysis of the results and looking into case mix adjustment. And then we'd like to use these data to facilitate the most fair benchmarking we can of clinical practice and quantify what extent of room for improvement there is and set realistic goals. And as Russell mentioned, this is critical at the moment, given that we're on the verge of drafting a new national action plan for the next 5 years. And then finally, point prevalence surveys that do allow us to identify those organizations that seem to be doing really well. Could everyone go on mute, please? And to showcase that work and celebrate that work, and importantly to disseminate it much more widely and allow other organizations to learn from what they've done. Next slide, please. And again, thank you. And again. So as you'll all be aware on this call, we have a UK National Action Plan to tackle antimicrobial resistance, and that we're coming into the final year of. And the targets from a prescribing perspective are to reduce human exposure to antimicrobials in primary care and secondary care. And the secondary care for this audience is most relevant in terms of reducing the drugs from the WHO watch and reserve groups from a 2017 baseline. Next slide, please. Now, these data come from fingertips and demonstrate the consumption of watch and reserve antibiotics by acute hospital trust. And what the slide illustrates is there's quite a bit of variation. But inevitably, in the world of stewardship, we're walking this fine line between the burden of data collection and using that data and putting it into action. And routine data such as this provides some insights and suggests that there may be room for improvement. But really, we're looking for more information to inform decisions about how much of this prescribing is appropriate and how much might be inappropriate. Next slide, please. Now, where point prevalence surveys really add value are they build upon the routine data that Russell mentioned, the dispensing data that we have from hospitals expressed as defined daily doses. So on the top table on the left-hand side, the determinants of resistance really are the number of individuals exposed to an antimicrobial, the duration of that exposure, and how frequently they're exposed. And looking across to the different measures we use, dispensing data can really only look at all of those three things together and not discriminate between them, and can't make any judgments about appropriateness. Point prevalence surveys start to bring in more information about how many individuals are exposed to antimicrobials, and there's some data on the duration of their exposure, and it allows a combination assessment as well. Now, obviously, the electronic prescribing and EPMA represents perhaps the ultimate in terms of surveillance, but we know that not every hospital has EPMA and not every clinical area has rolled it out. So other areas where point prevalence really supports is in the important aspect of quality improvement. So the green table at the bottom, linking the drug choice to a diagnosis or an indication. This is where point prevalence really comes into its own. And similarly, attribution of prescribing to a prescriber and a specialty to a team to encourage improvement. This is where point prevalence brings in that data as well. I've just lost the slides, Berit. Someone's sharing. There we go, thank you. And then dose regimen, point prevalence surveys allow us to bring in data on dose, as does e-prescribing, that's not visible within dispensing data. And there's a really important row missing from this green table that I realized as Professor Hopkins was talking, that children and pediatrics, so children are really not well represented within dispensing data, and point prevalence surveys allow us to explore antimicrobial exposure in children in more detail. Next slide, please. So finally, I mentioned about fair benchmarking and realistic improvement goals. So data from the United States show that different specialties are associated with different risk of exposure to antimicrobials. Some of that appropriate, some inappropriate, but there's clear variation between specialties. And so the point prevalence survey allows us to quantify the number of patients in different specialty beds in hospitals around the UK, and to start to bring in a case mix adjustment to determine, well, if we're just looking at routine data like dispensing, what volume of dispensing would we expect for a hospital based on its case mix? So this is just a taster of some of the really valuable information that can come from point prevalence surveys. And next slide. Thank you. So just in summary, I hope I've persuaded you that PPS adds value to infection prevention control and antimicrobial stewardship. I do think, and from my own personal experience, that participation in the survey builds multi-professional team working, strengthens your networks around your organizations, improves visibility of IPC and AMS, which is really important at the moment when there's so many other priorities. It also, from your point of view in a trust, demonstrates your commitment to IPC and AMS, and that is in partial fulfillment of the code of practice of the Health Act, and will act as evidence for CQC of your commitment to this. And then finally, participation of enough hospitals across the UK will allow us to really bring in some accurate case mix adjustment for the purposes of the next National Action Plan. And I'd like to hand over to Professor Diana Shiroro-Dopey. Thank you.
Thank you very much. So I think Russell and Kieran's share has provided significant information about the value of the PPS. I thought I'd just go back and just share, particularly focus around the antimicrobial use and the 2016 data that we have, and just to show you the sort of information that we can capture within the PPS. So that the image on the left side there is from ECDC's summary from 2016, and at that point we were participating alongside other European countries, and they have specific they have a spreadsheet that has all the data for each of the countries, and you can see there that we were able to, the amount of data that we could capture. This is just a section for antimicrobial use. There's significant data also from healthcare-associated infections, but we know through there that the proportion of antimicrobial use for the UK at that time, this was for England specifically, and there's equivalent for Scotland and Wales and Northern Ireland as they participated, was around 35% to 39%, the average being 37%. You can also see there are proportion for community infection, hospital infection, long-term care facilities that participated. Also critically, as has been highlighted, that ability to be able to drill down into the different types of indications and different types of specialty areas, which we can struggle to capture through other data points, as Kieran has mentioned. The image on the right there is from a paper undergoing a peer review at the moment, which just shows again around the age distribution that Kieran talked around, where we can see for each infection, and we focus this on community-acquired infections, what the age group is. So that allows us to kind of drill into where we want to target interventions. From the 2016 data, one of the key points that we used that data for was around assessing levels of inappropriate prescribing in the country. And for many years, there's always been the bandied about figure of more than 50% of antibiotic prescribing is inappropriate, but we didn't actually have a number. And so through the PPS data, because of the good participation across the country, we were able to use that data, working with an expert group to develop through a Delphi process to develop what they considered inappropriate prescribing to be, and there was quite a long process to determine that. But we were able to have a value or a number or proportion for the first time, which is evidence-based and focused for England. And at that point, it was calculated about 30% of prescribing was inappropriate based on duration or dose. There's some obviously limitations to the method that was used at that time, but again, that gave us a data which is based on evidence rather than what we've done in the past, which is looked at the literature to try and capture that or use individual data collected from some hospitals. Through the PPS, I think this point has been well made, is that we're able to develop and evaluate quality indicators at a national level. But because also we provide the data back to you at individual hospital level with some benchmarking, you can use that to develop interventions for your hospitals as well. And then it all allows us to follow up on antimicrobial stewardship and infection prevention and control programs, and to support decision making. At the bottom line, all of this that we do is really for patient safety. We're trying to make sure that patients do not get unnecessary antibiotic use, unnecessary antibiotics, and also that when they do receive antibiotics, it's for the right time, at the right time, right duration, and also making sure that it's using the appropriate or the best route for them. So we know, for example, that we have high levels of parenteral use at that point, and there's been some work currently in progress now around IV to oral switch and developing a criteria for that. So I'm going to pause there now. I'm going to hand back to Berit and Jocelyn, and just in advance to also say thank you to the colleagues who will be sharing learning from their participation in the 2016. I know definitely Kieran, I was validating data, so we visited Southampton and I think Hertfordshire at that time, but there are colleagues on the call who will share their experience of participating to let you know. Some of them will be very honest and in the terms of how hard it is. We know it's resource intensive, but hopefully that gives us opportunity to get valuable data. Thank you.
Great. Thank you very much to all three speakers. That was really fantastic. And as Diane has sort of explained already, the next session is about user stories. So where colleagues, Dr. Mark Gilchrist, Neil Wigglesworth, and Reem Santos will talk about their experience, how it went in their trusts in the last round. Can I hand over to you, Mark?
Yeah, sure.
Thank you.
Good evening, everybody. So I don't have any slides, so I'm just going to give you some thoughts really on how it went for us. This is really about how we operationalized it and coming from the shop floor, I guess. So within Imperial, we've developed point prevalence systems over the last 10 years or so, and really in adult and pediatric use. And the methodology we've always used is baseline, monitor, improve, and that allows us to give awareness, education, and feedback. And we do that through a process of agreement, engagement, and logistics. And overall, it allows us to deliver a method of surveillance and epidemiology, but both QI and audit at the same time. And really, I guess what the national PPS does is it helps us bring together the antibiotic side of things, which is our usual business in my line of work, but with the IPC, HCAI, vascular device angles as well into that antimicrobial use. And that synergy and benefit is critical, because the collaboration we have within IPC and AMS is key to tackle AMR, and it's a growing synergy of both disciplines. So as sort of Kieran alluded to, bringing those two together is a huge collaboration, and it can be quite fun as you're doing it. The national PPS for us is a good thing to do. It helps us with benchmarking data. We learn from other healthcare systems. We're able to provide answers to the problems that we have, and ultimately it benefits in optimizing our guidance, whether that's treatment or whether it's prophylaxis. It identifies gaps in our systems, so no system is ever perfect, and we certainly have improved our systems based on the surveillance that we've been able to have, whether that's the gram-negative agenda or the positive or IV durations, or just whether it's a device-related infection, and that benefits both ourselves, the locality, and the patients coming into us, which is important. And it's a peer review in a way. Imperial itself is made up of 3 hospitals, and we had a really honest discussion about how we were going to do that. And actually, we chose one of our hospitals sites to do that. We didn't have capacity at the time to do all 3, but we did one because we feel this is an important initiative to support. And we twinned that, as I said, with IPC. We built our timelines around our local point prevalence approaches. Does it take time? Yes. Can it be managed? Yes. Is it worthwhile? Yes. And the data collection needs planned. And if you can manage those expectations and get the buy-in and stakeholder engagement within your organization, which attunes to all the NICE guidance and the other legislation and the Health and Social Care Act, then it works really well. So from us, we will be hopefully participating, and we will be looking at all of the parameters I've discussed. So it's a challenge, but it's very doable. Thanks.
Thanks a lot, Mark. Neil, would you like to also say a few words?
Me, Neil. Sorry. Hello?
Hello, Neil. We can hear you.
Yeah. Sorry, I'm afraid I am I've been unable to get off the motorways. I'm completely stuck in traffic, so I'm just listening. I don't think it's safe for me to really think and speak properly. I'm stuck in traffic on the motorway. Apologies.
Shall I send it back to you?
That's me. That's the next one.
Yeah, but we haven't got the full idea. Okay. So then, Reem, can we hand over to you? We just need to upload your slides. Maybe if you could start, and we do our best to get them on screen as soon as possible.
Absolutely. Sorry about the background noise. So I'm going to share the Cambridge experience, which I've done twice, back in 2011 and 2016. And sorry, I'm just looking for the slides, but essentially we are a 1,100 bedded hospital with 40 plus wards. We've got 2 critical care units, 3 HDUs. It's quite a large teaching hospital with multiple specialities. And we are also a tertiary referral hospital. We've got a large liver unit, and we offer intestinal transplantation, and one of the few in the country that do also multivisceral transplants. So we are high users of antibiotics generally, and we certainly see our fair share of healthcare associated infections. Next slide, please. So back in 2011, we were doing things still on paper. So a lot of the work was just a little bit more difficult than it is now. So we introduced ourselves to the nursing team, the nurse in charge when we went to the wards, requested from the ward clerks to generate lists at 8 AM so that we knew which patients were on the ward at that time. And we were lucky enough to have some regional IPC buy-in from the lead nurse at the time. And she assisted with some of the training and also the data collection. And in 2016, we had a fully integrated EPMA system, which was just transformed the whole process. And I know that many trusts are now in that position. So I'm hoping that it'll be much easier for everybody in terms of data collection. So we were about 2 years into our EPMA system, and we were able to get lots of information, from laboratory information to medication in terms of antimicrobial prescribing, to any sort of devices that the patients had. Some accuracy issues, so were a little bit of the drawback. So we were often having to do this to save time by doing this virtually rather than going around the hospital and seeing patients at the bedside, which is what we had to do in 2011. And so sometimes we would find that perhaps if all the information was very much down to user input. So if the patient had a catheter, it may have been documented as being there for quite a substantive period of time. And that would sometimes prompt us to then go ahead and search more fully within the record rather than actually going to the ward and seeing the patient. If we did have queries, we would save them aside to the end of the review, and then either phone up the ward or go and visit the patient at that stage. Next slide, please. So we divided up the work amongst our IPC nurses and microbiologists and the AMS pharmacy team, which at the time, I believe was probably just me and perhaps a junior pharmacist. So there were very few antimicrobial pharmacists with us, and we ended up allocating each ward 2 volunteers, and that was always done with a consultant twinned with either a pharmacist or an IPC nurse. And despite all of this, it was quite onerous. And as we were trying very hard to be completely electronic, this kind of didn't really work, we found, with the point prevalence. Next slide, please. In front of you, you can see some examples of the forms that we had to complete, and we had to complete a form for every ward, listing all the patients that were on the ward and whether they had any healthcare associated infections and any devices, any antimicrobials that they were prescribed at the time. And we had to categorize a lot of these with specific codes. In fact, there was an entire handbook just for codes. So I'm just preparing everybody. There's a lot of learning, there's a lot of looking up. It is very resource intensive, but you do learn a lot in the process as well. And if you happen to have and be on antimicrobials or have a healthcare associated infection, you then had to complete another form, separate forms for healthcare associated infections. The one before you is on antimicrobials, and I think the next slide might show the healthcare associated infections one. So that's it there. So for every patient, you had to drill down into quite a lot of detail, which is a lot more difficult if you don't have an electronic prescribing system. So just be prepared to be going through lots and lots of notes. And often, I think some of the issues that we had were around the definitions. We had to go through. We had to put down lots of different codes, and sometimes it wasn't really clear if patients were prescribed antibiotics for treatment or prophylaxis or a bit of both. And trying to decipher that is probably where the time-consuming element really came in. And then you also had to look into the microbiology aspect and jot down any positive microbiology results along with the susceptibility profile of the organisms. And here is just an example of some of the definitions and some of the codes that you may very well see. Things that I felt would have been helpful perhaps is to have these in some sort of alphabetical order, because I found you're just scrolling through the list trying to figure out what works with this particular patient that you've got in front of you. And that was probably for the specialty code list. For the infection site code list, I could see that it was grouped according to body system, but I felt that perhaps it could have been grouped in not just made a little bit more visible. So perhaps an extra column or different color scheme so that you could see that, this is respiratory, this is ENT, etc. Because actually when you're doing this, time is of the essence, especially if you do it as we did with a microbiologist. We'd have an hour to see as many patients as we can, and then if we don't have time, we'd then have to reschedule it for another day or another time period. And I don't know if I've come to the end.
Yeah, I think
yes, and I think that's it really.
Thank you very much for the honest and helpful feedback. We have taken notes, and we will also later in sort of user groups ask for exactly this type of feedback. So thank you both very much, Mark and Reem. And now it's Jocelyn's and my turns. Just to give a brief overview of the national, sort of the plans for the national PPS this year, and give you key dates and sort of, more info about the process. So if I kick this off, just, we've talked a lot about the usefulness, and that we have done previous point prevalence surveys in England. The last ones performed based on the ECDC protocol were in 2011 and 2016. And in these tables, you can see sort of the changes in HCAI prevalence. And on the lower sort of table, I just highlighted sort of the top healthcare associated infection sites. They were similar in 2011 and 16, sort of top pneumonia and lower respiratory tract infections, followed by UTIs and surgical site infections. Next slide, please. And participation, I mean, we were really, yes, very positively surprised by how many of you registered for this webinar, how many are sort of planning to participate. Jocelyn will give a little bit more info on this. But also in previous PPS, I mean, we had a lot of support, many trusts participated. So this little table with the yellow highlights, that was the sample calculations provided by ECDC, our European, the European Centre for Disease Control, to give a representative sample. In the UK, England had to provide, or 36 hospitals, so last column on this table, needed to participate. And as you see further up on the bullet points, in 2011, we had 100 trusts participating and 94 trusts in 2016. So a lot of support from colleagues. Next slide, please. So something that Reem obviously pointed out, we are really trying to facilitate data collection. I mean, there's only so much we can do. Of course, there will be a lot of work involved on site, on the wards, but we are exploring linkage to routine laboratory surveillance data sets, so data that we have already, and how we can incorporate this into sort of the data set, the PPS data set, and how much of the information can actually be provided pre-survey. So outputs we are planning to provide. We want to make benchmarking possible. It's something that Kieran also pointed out as very important within the data capture system. So comparison among sort of similar trusts. Then we will provide an initial trust level report for your trust, and then national reports, so comparing all trusts that participated. Last time, we also published a final national report in the SPOWER, so the English Surveillance Programs report, 2017, planning to do the same this time round. And then last but not least, of course, it's always very valuable also to share it with international colleagues, international experts. ECDC have just finished their round of point prevalence surveys in EU member states. And we are also collaborating with the Transatlantic Task Force on AMR TATFA, coordinated by the American CDC. Fine. So now I'm handing over to Jocelyn.
Okay, so I'm going to go through my slides quite quickly in the interest of time, but just wanted to give you a brief overview of who's participating in our in the expression of interest survey, who answered that survey and who might be attending today, and the level of interest in the point prevalence survey itself. So the expression of interest survey that you've completed to participate in this webinar today, just over a third of those answering this expression of interest survey were nursing staff, and the second most common profession was pharmacist, and the third most common was DIPSI, assistant DIPSI or IPC lead. And we had good representation across all regions through the expression of interest survey, and good coverage across most. Over half of you answering the survey were very likely or somewhat likely to participate out of 375 of you who answered the survey. And over half had participated previously, but interestingly, 40% had never participated. So just a brief overview or high-level summary of the process and some key dates for you. So in June, we will plan to send out invitations to all trusts to participate in the National Point Prevalence Survey. As we said in our expression of interest survey, that was not a commitment to participate. We will send out formal invitations in June. And we also plan, and thank you so much to everyone who responded to this question on the survey, saying that they would like to participate in user groups and pilot testing of the system. So those will begin in June and continue to mid-July roughly. After this, we will have a registration period, which is when your After invitation, should your trust choose to sign up to participate in the point prevalence survey, you will be then, there'll be a period of registration where you'll be registering your trust and providing hospital level data during July to mid-September. We will also be holding training days, so these will be live events, and these live events will be recorded, and the recordings will be made available to all registered participants, and these will be made available also on the help pages of the data capture system. And those training dates are, we haven't have the exact dates now, but they will be between mid-July and mid-September, bearing in mind that there's a summer holidays over that period. So we wanted to have the recordings available so that people could watch if they are going to be away during a live event. So the proposed survey period, there's also a validation exercise where in previous years, UKHSA staff have gone into randomly selected trusts to validate the data being provided through the survey. And so those are carried out concomitantly, so at the same time. And those, we're proposing those to happen during the last 2 weeks of September. So that's being the 20th of September to the 3rd of October. And then we acknowledge that there is maybe additional time that's required for uploading all of the data and completing all of the survey data collection. And so we anticipate survey data completion, all of the data being collected by the end of November this year. Okay, I'm going to hand over to Berit.
Okay, thanks, Jocelyn. So now we've got a little bit of time for discussion, for questions, thoughts from you. Thanks a lot to Diane and Susan, who have already responded to some of the questions in the chat. If you would like to raise anything now before we sort of move to the closing remarks.
There are a couple of questions in the chat. Should I just, but some of them Susan and I have replied, but there's a couple that I think may be best suited for you. How different is the documentation from 2016?
So the protocol, we're using a similar protocol, but we're looking and exploring ways in which we can reduce the amount of direct data capture, as Berit mentioned in her presentation. So we're looking into what we can use from existing surveillance data sets that will come in with live feeds for us, so we can do that linkage instead of requiring trusts to provide that information during the survey period.
There's another one here. Do we have a date? Sorry, go on, Berit.
It will also be opportunity. I mean, that is the point of the user groups, you know, to also explore whether there's any additional information that we should be capturing. But of course, it's a fine balance, you know, to keep, not to add too much or make it even more labor intensive. But yeah, it is based on previous protocols.
Do we have a data collection platform tool or just another Excel spreadsheet is another question.
So the data collection tool, the platform is being developed. So that will be available for pilot testing. And so we will leave it up to the trusts whether you want to collect information on a paper form first and then on the day and then upload it all in one go in that additional time given to data uploading. But alternatively, you can input the data directly on the data capture system. Yes.
Will the various training days cover the same aspects or different ones? So we need to attend more than once. This suggests Veronica was part of the previous PPSs. So will it be the same training content when we get to having training days?
Yes,
yes,
one.
It's the same content. There's a question for Reem, but I believe what type of training did the regional IPC nurse provide? So I don't know if Reem's still on the call.
Yes,
I
I was just saying that it's it wasn't very extensive, but we had one of the microbiologists and the IPC lead nurse for the hospital attend the full training day that was provided at Colindale at the time, and this was just helpful because the regional nurse was just able to provide a little bit more support to the rest of the team, really, but it wasn't anything in any formal sense whatsoever.
I think final one is, does the size of the organization matter? We are a small private, actually this is a good question. So can private hospitals participate? And also there was a question about community and mental health trusts. I think it's just helpful to verbally say that.
Yes, yes, we welcome private independent providers of healthcare. And also this year in previous years, it has focused on acute hospitals only, but we, having had some feedback from regional colleagues, NHS England regional colleagues, there's a big gap in our understanding of the levels of infection and antimicrobial use in community and mental health trusts. So we are welcoming community and mental health trusts to participate this year.
In the interest of time, probably you can carry on or try and continue answering the questions in the chat.
Okay, that's great. Thank you, Diane. Yes, then let's move to the closing remarks. We have one speaker very kindly agreed. So if we start with Samantha Matthews, the National Clinical Lead for Infection Prevention Control Programme at NHS England, and then hand over to Colin Brown, Director for Clinical and Emerging Infections and Deputy Director, HCAI, Fungal AMR, AMU and Sepsis Division at UKHSA. Sam, can I hand over to you?
Yeah, hi everybody. Thank you so much for giving me the privilege of joining Colin in closing this webinar, which has clearly demonstrated the positive outcomes of our participating in the next point prevalence survey, and central to this is the safety and quality of care to our patients. So thank you everyone for attending. It's been wonderful to see so many colleagues here today, hear their experiences and share their learning. We know that any point prevalence survey is an intense period and requires substantial resources over a short period of time. And having been part of the point prevalence surveys in the past, I can certainly share the experiences of some of our speakers today. But as you can see from colleagues and will be aware from your own experience, it also provides important benefits as well. The point prevalence survey is an opportunity once every 5 or so years to understand the prevalence, for example, of UTIs, skin and soft tissue infections, ventilator-associated pneumonia, within our systems, our own organisations, systems, regions and across England. And this enables us as a multidisciplinary team to look beyond our mandatory reporting requirements. As mentioned by Mark, it uses standardised measures for levels of infection to reduce variation and to enable comparison between organisations, systems and across the country and over periods of time, which is so important with our new frameworks and reporting within NHS England and changes going forward. This is particularly important when we consider information on device utilisation, which we do not usually capture in a standardised way in any other surveillance. So in summary, the point prevalence survey provides us a collaborative healthcare response to support capability, capacity and culture to reduce preventable harm to our patients, to identify areas for further scrutiny and intervention, working together. It supports the delivery of quality improvement, surveillance and assurance to enable system transformation in relation to IPC, along with AMS. It enables our healthcare system providers to develop a positive IPC culture for assurance, for quality standards by operationalising IPC guidance, for example, the implementation of our National Infection Prevention Control Manual. And this promotes a culture of patient safety, focusing on reducing the risk of harm caused by preventable infection. It reduces unwarranted variation and ultimately improves health outcomes for our patients. And we welcome your participation in September and look forward to seeing the results. And I will now hand over to Colin.
No, thanks so much, Sam. So I've just been finishing up a research AMR meeting in Edinburgh, and I think one of the key things arising out of that is the need for standardized data. I mean, Sam covered it very, very nicely, but to be able to argue for improved services, greater funding, to develop our evidence-based to benchmark where we are, both nationally, regionally, and within organizations, to look at kind of international comparisons, identify the key unmet needs, looking at different types of kind of bacterial classes that we need to focus on, looking at the variety of healthcare associated infections and drug resistance that is happening in our hospitals. We get a lot of that from the routine data feeds that we have, but it really sometimes is without the surrounding metadata. The point prevalence survey is so valuable in giving us additional flavor of information that really will help from everything from modeling to looking at intervention studies to looking at where we invest laboratory and diagnostic capacity. So I'd really just highlight all the great work that people have done to bring this to fruition, and would very much encourage people to participate.
Thank you, everyone, very much for participating, for joining us today. And yes, we will be in touch. Thank you. Bye.
Thank you.
Thank you.
Diane, is that a legacy hand?
Thanks.
Thank you.
Bye. Thank you.